to our presenters. At the end of this session, the moderator will address questions that have been placed in the chat panel. So please send any messages that you have in the chat and send to everyone. If you need any technical assistance, please send a direct message to myself or one of the co-hosts and we can assist you. At the end of this webinar, please fill out the survey so we can make our next events even better. And before we begin, just to note that the views expressed by speakers, moderators and participants during this pre-COP6 online event are those of the individuals concerned and do not necessarily reflect the views or policies of the Secretariat of the Minamata Convention on Mercury. And with that, I'm going to hand over to Benoit.
Thank you very much, Maya, for this important note. Hello, everyone, and welcome to this event in preparation of COP6, organized by WHO in collaboration with UNEP and as part, of GEF7 project phasing down the use of dental amalgam. So this is the third pre-event dedicated to dental amalgam issue, reflecting, I think, the continued interest of countries and partners in this topic. So my name is Benoit Varenne. I'm leading the oral health program at WHQ Geneva. I'm joined with Dr. Gabriela Sardon, who coordinates the GEF project for WHO and will co-host this webinar with me. So we have today a fantastic agenda with great speakers, a mix of scientific experts and policymakers. Will show how scientific evidence support national decision making. So translating scientific facts into health policy is part of WHO core mandate. And so the first part of this webinar will present the outcome of 2 years of international collaboration, consultation, review, and analysis of the latest scientific evidence, which led to the development of the first ever WHO Guidelines on environmentally friendly and less invasive oral health care for preventing and managing dental caries. The second part of the session will highlight 2 very interesting country experience, Uruguay and the Philippines, regarding regulation and the progressive phase out of dental amalgam use in these countries. So please keep in mind that we have secured a bit of time at the end of the session to respond to the question, but we encourage you, to submit your question in the chat box, and we'll select a few questions at the end to open the discussion with the speakers. As you know, more or less, all WHO works with countries to improve oral health and ensure that clinical intervention, dental clinical intervention are equitable, affordable, and safe for both people and the planet. So we have strong country engagement, which has led to the development or implementation ongoing of the Global Oral Health Action Plan, and also a number of additional political declarations. I put here the Bangkok Declaration that really are both aligned, with the convention, the Minamata Convention on mercury. And the Global Oral Health Action Plan also includes monitoring of progress made by countries. And one of the 11 targets of the action plan relate to the implementation of the measures under the Minamata Convention on mercury. And as you can see on the slide, the goal of reaching 90% of countries by 2030 that have implemented the convention measure or phase out the use of dental amalgam is still far from being achieved. So only at this stage, 31% of countries, have met this objective. And this is why, WHO and UNEP, with financial support from the GEF, decided to collaborate and to accelerate the implementation of measures related to dental amalgam. So the GEF7 project, it's the name, what we call, is now entering its final year implementation, and many results are already visible in the 3 targeted countries, Senegal, Uruguay, and Thailand. Among the project achievement in the development is the development of the WHO Guideline, and it's for us and hopefully for all, a major step forward in supporting countries to phase out dental amalgam use. So without further delay, I would like to introduce our first speaker that will intervene via a pre-recorded video. Is Dr. Katia Gédéon, is assistant professor at the Faculty of Odontology, Paris-Cité Université, France. She led the international systematic review team commissioned by WHO to conduct 5 systematic reviews that inform the development of the WHO guideline. So she will present the scientific foundation of the development of this WHO guideline and the result from the systematic review. So now it's a video. So I'm requesting Maya probably to upload. Thank you.
Hello everyone. I am Katia Gédéon from the University of Paris-Cité in France. I would like first of all to thank all the organizers for giving us the opportunity today to share with you the main findings from our systematic reviews. At the request of and in collaboration with the World Health Organization, we conducted 5 systematic reviews to answer 5 key questions. What are the clinical and cost effectiveness, the cytotoxicity and biocompatibility, the monomer release, the potential health and environmental effects of mercury-free dental materials? To do this, I brought together a team of researchers and experts from various fields representing different universities and countries around the world, as you can see on this map. Our systematic reviews followed the PRISMA checklist, and all our protocols were registered in Prospero. We search all major databases, as you see on the slide, from the earliest available date up to July 2024, and updated our search in March 2025 to include the most recent relevant publications. Our research focused on materials used for prevention of caries, such as fluoride varnish, silver diamine fluoride, glass ionomer sealants, and resin-based sealants. We also included materials used for caries management, such as resin-based composites and compomers. A total of 158 studies investigating preventive dental materials were included. Among them, 35 original studies and 21 systematic reviews concluded that fluoride varnish and glass ionomer sealants both reduce the risk of dental caries. Fluoride varnish, especially 5% sodium fluoride, applied twice a year, significantly decreases caries risk. Resin-based sealants show similar efficacy to fluoride varnish but perform even better when applied every 6 months. Silver diamine fluoride was found to be slightly more effective than both fluoride varnish and placebo. Regarding caries arrest and non-restorative treatments, we included 26 randomized controlled trials and 21 systematic reviews, covering both primary and permanent teeth. The data show that 38% silver diamine fluoride applied twice a year is the most consistently effective agent for arresting cavitated carious lesions and root caries. In addition, 5% of fluoride varnish, whether used alone or in combination with a sealant or an infiltrating resin, is effective in arresting non-cavitated carious lesions. For restorative materials, the great heterogeneity in materials, clinical protocols, outcome measures, and comparator groups across studies did not allow us to perform meta-analysis. However, based on the assessed outcomes, such as restoration survival, secondary caries, and root caries, we can conclude that mercury-free dental materials are effective in preventing new caries in occlusal restorations when properly placed. They are suitable for use in various cavity classes without increasing the risk of new caries. There may also be a potential benefit of modified glass ionomer cements for managing root caries, although the available data remain limited. When it comes to cost effectiveness, we looked at 42 studies covering different types of economic evaluations, mainly cost effectiveness, cost utility, and cost benefit analysis. Overall, preventive approaches like fluoride varnish, sealants, preventive programs, silver diamine fluoride, and glass ionomer cement are cost-effective options for managing dental caries. Now, regarding cytotoxicity, all the available studies were in vitro, not conducted on humans. These studies show that some composites can be cytotoxic under certain conditions, especially when polymerization is incomplete. But the good news is that with proper light curing and good isolation of soft tissues, this risk can be largely avoided. And today, new generations of composites no longer contain those monomers, making them much safer to use in clinical practice. Similarly, 169 studies analyzing monomer release found that some materials can, under certain in vitro conditions, release monomers such as BCMA, which is a BPA derivative, that may have endocrine disrupting effects. However, proper light curing and good isolation can significantly reduce exposure to these monomers. When looking at possible health effects, 98 studies reported issues such as allergic contact dermatitis and respiratory irritation among dental professionals. These effects can usually be prevented with proper protective equipment and correct polymerization. Most of these studies are based on in vitro experiments and case reports with limited long-term data. Overall, the reported effects are generally mild, reversible, and preventable. Only 14 studies have looked into the environmental impact of mercury-free dental materials. Overall, these studies show that preventive agents have the lowest environmental impact, followed by glass ionomer cements used for direct restorations. So, even though the data are still limited, it seems that prevention and the use of certain restorative materials could be more environmentally friendly options. To conclude, all these findings show that mercury-free dental materials used for caries prevention and management are clinically effective. However, more research is still needed to confirm the long-term performance, and the data on environmental impact remain limited. Some components can be toxic, but proper use and good polymerization significantly reduce exposure. Following manufacturer guidelines and proper protocols helps minimize any health risks. Overall, these materials appear to be environmentally friendly, especially the preventive ones. I would like finally to thank all the members of my team who worked a lot, and thank you very much for your attention.
Thank you, Katya, and thanks for the entire team. Your team, have been really done amazing work. So next speaker is Professor Eduardo Bernabe, Professor of Dental Public Health at Queen Mary University of London, UK. Professor Bernabe is a global health leader with expertise in generating robust epidemiological evidence to inform health policy and planning. He also works as a consultant for various international organizations, including WHO Health Program, supporting the development of the guideline presented today. So please, Eduardo, over to you.
Thank you, Benoit. Hello, everybody. What I am going to do in the next few minutes is just to give you an overview of what happened once we received the evidence from the systematic review team, the evidence that you just saw from Katya's presentation. So I will reiterate this figure just to remind you of the different products that were evaluated by the systematic review team, but also in terms of classifying them according to what they are meant to do in terms of prevention and in terms of caries management, restorative and non-restorative, because that is more or less how you will see the recommendations being organized later on. Before we started the discussions of the evidence with the guideline development group, we set up some guiding principles that you see listed here. The most important one probably was the idea that prevention comes first. Is probably the most effective way to reduce the need for further dental treatment. And of course, on top of that, we have also early detection and minimally invasive care. The idea that we need to have an open communication between patients and health professionals for real patient-centered care. And finally, also the precautionary principle, whereby safety and environmental responsibility are priority, especially when the evidence is limited or incomplete. So with that in mind, we use this framework, the WHO integrate framework, to move from evidence into recommendations. So as you can see in the circle, in the green circle in the figure, we start with the quality of evidence that Katya's team summarized recently. And then we took into account 6 different domains during these conversations. I'm not going through all of them, but just to give you a few examples of the discussions. There were discussions about the feasibility of some of these products, the acceptability of some of these products, and also how they can actually increase or decrease inequalities in the long term. Okay, so all those considerations were taken into account when proposing recommendations by the guideline development group. So with that, the group came up with 8 different recommendations and 2 further base practice statements. And they were organized into two groups. The first group on the left is in terms of recommendation for clinical practice, for prevention, for non-restorative treatment, and for restorative treatment. And then on the right side, you have the recommendations for risk mitigation, where you have also the best practice statements. So going into the actual recommendations, I'm not going to read them out loud. I mean, I hope you can actually see them clearly. What I will say is that when you see a box in dark blue, then that means a strong recommendation because the evidence was of moderate certainty. But when you see a light blue box, it means that the recommendation is only conditional because the certainty of the evidence was low. Okay, so in terms of prevention, I mean the three products had some effect, especially fluoride varnish on the top and then fissure sealants at the bottom. For silver diamine fluoride, the recommendation was only conditional. Now, moving into non-restorative treatments, the 2 recommendations were strong. And what I would like to highlight here is the text in blue. So fluoride varnish is recommended for managing initial caries lesions, non-cavitated lesions, while silver diamine fluoride is for arresting cavitated caries lesions. Moving into restorative treatments, there was sufficient evidence to make a recommendation regarding the use of glass ionomer cements and resin-based composites, although the evidence is low certainty and the recommendation is conditional. Now, moving to the second group of recommendations, they were split into two subsections. One is the provision of oral health care for vulnerable groups. And here is more or less what Katia was summarizing in her recorded presentation about the possibility of being exposed to bisphenol A derivatives from certain products, particularly resin-based composites, either in terms of fissure sealants or fillings restorations. And because BPA has been declared or listed as an endocrine disruptor, the GDG decided that it was important to find a way to limit the use of these products in children, adolescents, pregnant, and breastfeeding women, because they are more susceptible to endocrine effects. And in relation to that as well is that any individual with some form of allergic condition should also be treated differently, I suppose, and with certain caution when using these products. Now, the evidence, as Katia pointed out, is still growing, is low certainty, and that is why these two recommendations are conditional. And the last set is in relation to how we can mitigate those risks for both for patients and clinical teams. And because evidence in this area is indirect mainly or mostly, there was no way to grade the level of evidence. And that is why the GDG decided to go for best practice statements. As you will read them, you will see that they make perfect sense, and that is more or less how you expect clinicians actually to handle this kind of materials, resin-based composites, in terms of adhering to occupational safety protocols and also trying to minimize exposure to unpolymerized monomers from the application of these materials. So the guideline, the printed guideline, will also have some specific chapters in terms of implementation considerations that were organized around those 4 topics you see on the left. And then also some information about the gaps in knowledge that need to be filled if the recommendations are to be updated in the future. And the last slide is in terms of trying to sum up all this into a few take-home messages. And I think probably the most important one is that the best way to minimize the environmental impact of oral health care is to reduce the need for treating preventable oral diseases. I mean, prevention, as I said earlier, is important. But now we believe that there are mercury-free dental materials that could be used, as well as non-invasive techniques to prevent and to manage dental caries. And finally, looking ahead, we need to start thinking about delivering oral health care in the most environmentally sustainable way. Thank you.
Thank you very much, Eduardo. Just to mention, of course, to all the participants that this WHO guideline will be released very soon, hopefully before the COP6, so by the end of this month, and we'll keep you informed, of course, once it will be the case. So thanks again, Eduardo. You have been a pillar on this work. So I have now the pleasure of introducing the professor and director of the Clinic for Conservative Dentistry, Periodontology and Digital Dentistry at Ludwig Maximilian University Hospital in Munich, Germany. Professor Falk is research span restorative and preventive dentistry, diagnostics and AI, health economic and public health. So Professor Falk is associate editor of the Journal of Dental Research and leads working groups at FDI and ISO as an example. So over to you, Falk. Thank you.
Thank you. And thanks for having me. And I'm taking the ball right up where Eduardo left it with regards to the alternative materials. What do we really have? And I want to make the case that there are alternative materials. I want to highlight which ones they are. And I will focus a lot on one material class, which was already mentioned today, which are the glass ionomers, because that's one of the alternatives where I think we are pretty close to, at least when it comes to the handling and the placement of these materials, to amalgam being very easy to place, being rather fast to place, maybe also being cost effective to place. And on the other hand, it's a class where we have increasingly sound data supporting its usage, and I will show you that. And I will start with the question, why are we talking about glass ionomers as amalgam replacement? Because for decades, we always said, at least in German dental schools, people said, this is a temporary material, you shouldn't use it in the permanent cavity. And I will show you a case, and for the non-dentist here, this is a molar, so a lower big tooth where an old restoration is failing, the old restoration was removed, the carious tissue was removed, and then someone placed in a rather large chewing loaded cavity a glass ionomer material. As I said, a material which traditionally was not used for these indications. And as you can see, even aesthetically, I think for both the dentist and the non-dentist here in the room, this is a nice filling. It will certainly cover what patients expect. And obviously the treating dentist, and in this case, it is a case from colleagues from Croatia, they also thought it would do the job for managing the cavity. And the reason for why we can do this is the data, the clinical data. And this is clinical data which we compiled a while ago already for changes within the German healthcare system. And I don't want you to read that table. It's the last decade of data on glass ionomers in the posterior dentition, mainly class 2. So really loaded cavities. And what is most important, how good does this material fare? And if we look at the annual failure rates, we're seeing something very fascinating. We're seeing something which 10 years ago may have confirmed the notion, yes, this is only a temporary material. Rates of 5, 6, 7% annual failure rates were probably too high. But we also see that over the last decade, something happened. Something happened with the material, and I will cover this in the next slide, which has led to lower annual failure rates, rather in the range of 2, 3, 4%. So fully acceptable when you think about clinical performance. And there are 3 reasons for that. The reason, number 1, is that these materials have changed with regards to the glass technology. I will explain this in a second. And the second reason is that these materials are by now oftentimes covered with a resin coat, which is supposed to increase the setting reaction, to improve it, to make the material more long-lasting, but also to improve surface resistance against erosion, abrasion, so any kind of acidic stuff, and flexural strength, protecting the material against break, fracture. I was asked to briefly introduce that technology here, so I will do this. These glass ionomers, they contain 2 phases, a glass phase, which you can see here, these particles, and a fluid phase. The fluid phase with the acid attacks the glass phase, and you get a setting reaction as well as a self-adhesive mechanism to the dental hard tissues by ionic bonds, so very strong self-adhesion, curing in bulk without any shrinkage, which is great. But that material class, based on the glass component, had a problem mainly with fracture resistance. And this has evolved over the last decade quite a lot into something which we now oftentimes also call glass hybrids, which the term is not without any problems, so I wouldn't overstate it. We can use the term glass ionomers nevertheless. But the difference with this new evolutionary step is that we have longer chains in the acids, and we have a second phase of a higher, a smaller particle in the glass phase. And that smaller particle with a higher surface to volume ratio leads to better cross reaction and hence better surface and fracture resistant. That said, for me, the most important thing is clinical data. I'm a clinical scientist mainly, and that's why we try to always look at randomized controlled trials, clinical trials. And this is, from my perspective, the most important trial in restorative dentistry over the last decade, where this material class, a glass ionomer, in this case it was Equiforte from GC, was tested in 4 different centers by 4 different independent groups in class 2 in adults. So really the situation where we want these materials to work if we are talking about amalgam replacement. And it was followed up for 3, and in the next slide I will show you the 5 years data. And what was done in that study in a randomized fashion, the material was compared against a composite, where we could say, well, this is already an accepted amalgam alternative. And if we manage to have the glass ionomers faring roughly the same, then we are really at an important stage for the whole discussion of making the case for glass for amalgam replacements. And this is the survival curve we have yielded in that study, where we compare the failure of glass hybrids versus the composites. And what is most notable is there's basically no difference. These lines largely overlap, so the annual failure rates over the 3-year periods were nearly exactly the same between the glass ionomers and the composites, which was really astonishing at that time, particularly coming from 4 different independent groups in a trial with over 300 cavities, which is a rather large trial, at least in dentistry. This is a 5-year data, and you can see that for survival, so the restoration surviving, the survival curves are still roughly the same on the middle there in that graph. For success, including those cases where you can maybe repair the cases, we see that over 5 years we get a little bit more failures in the glass ionomer group than in the composite group, and that's also highlighted here in the table. The majority of failures, if they occurred in the glass hybrid group, were repairs, where you can manage the margins in some kind of way, but you don't need to exchange the whole restoration, which of course from a clinical perspective is very important, but it's also important from a health economic perspective. And we conducted some years ago a cost effectiveness study comparing in these 4 different countries, Croatia, Italy, Serbia, and Turkey, the cost effectiveness of a glass-based material based on that randomized trial and the composites. And you can clearly see that, if I want to highlight this here, in nearly all of these 4 centers, the glass hybrid material came with significantly lower cost and very similar effectiveness compared with the composite, which of course is a huge argument if we talk about amalgam replacement, because cost was always one of the big pros of dental amalgam. Of course, these materials increasingly overlap composites, glass hybrids, resin-modified glass ionomers. And if you look at that whole spectrum of properties, and I don't want to go into detail here because I was given only 8 minutes and I want to stick to my time, you can see that along these different properties, we have some pros in the glass hybrid arena, we have some advantages in the bulk film composite, and some overlap in the resin-modified glass ionomers. But overall, for me, the message of the table is we have an increasing choice if we want to tailor our amalgam replacement therapy, our post-amalgam restorative dentistry in the posterior dentition, because we have different materials. What was also mentioned already by Eduardo and also by our first speaker is we have more alternatives out there. At least in the research realm, there are different classes, and I show you 3 materials where there's a lot of discussion at the moment if they could also be added to that field of amalgam replacements, the so-called alkasides or the composite glass hybrids and the resin-free ionomer composites. All of them are basically combinations maybe or obliterations of the classes we saw already. And I think they're very interesting. You can see that they have different properties like very low polymerization shrinkage, no bonding step involved, or releasing alkazine ions. But the main problem at the moment with these 3 materials is we don't have any clinical data spanning longer than 6 to 12 months, at least when it comes to really randomized controlled trials, or the materials are not available on the market at present. So the message of that slide clearly is, yes, there are alternatives beyond the composites and the glass ionomers, but the evidence and the availability is maybe a certain limitation here. So for me, the conclusion is, on the one hand, very clear, and on the other hand, quite ambiguous. We have amalgam replacements, quite a range. They all have their unique strengths and weaknesses. The glass ionomers are, I think, one of the strong avenues down the road. They have a good cost effectiveness and increasing supporting clinical data, but certainly we need more clinical trials, we need better data, long-term data, and we also need to investigate these new alternatives.
Thank you very much, Falk, to contribute to the discussion and show all the alternative to dental amalgam now are more and more available, effective, and could help really and support countries in moving toward the end of the use of dental amalgam. Thank you so much. Now let's move to country experiences. It's important to, again, translate this quite strong evidence we have now. So our first speaker is Mrs. Judith Torres, Manager of the International Agenda and Cooperation Office, National Directorate of Climate Change, Ministry of Environment, Uruguay. Judith represents the Ministry of Environment in the implementation of the GEF 7 project, which she co-leads alongside the Ministry of Health of Uruguay. She's currently serves as co-chair of the Global Project Steering Committee. So over to you, Judith, and welcome once again.
Thank you, Benoit. Good morning, good afternoon, good evening to all the attendants of this webinar. Next slide, please. I'm here to present Uruguay experience with dental amalgam. Here in Uruguay, we focus on prevention, alternative materials, and best practices, as well as managing the legacy of dental amalgam. Next slide. As you can see in the slide, Uruguay is not a populated country. And thanks to the national health system, dental practice is included both in public and private health hospitals. Next slide. This slide illustrates the milestones that led us to decide on the phase out of dental amalgam. The negotiations for the future convention on mercury further encourage our move to phase out dental amalgam. Coordination among ministries of environment and health, along with other institutions, private and dental clinics and academia, and also capacity building on waste management, it was key to this process. There you can see that we have incorporations from WHO, that we have a reduction of the academic level in practice or in teaching dental amalgam. Then after the signing of the Minamata Convention, we became part, we were the second country in being part of Minamata Convention. And after that, it was a kickoff of different actions that make the academia, the Faculty of Dentistry in Uruguay, to eliminate the teaching of dental amalgam in the curricula. And also we were working on a decree that attend the mercury added products. At that time of the decree, we didn't incorporate the dental amalgam into that. But now, after these projects and all the actions that were gradually taken us to the phase out, we will be making some amendments to that. Next slide. As you can see in this slide, the phasing out is multifactorial, mapping main actors and focusing on prevention, as well as new materials and best practices, was essential to go along with this process. Next slide. So the CHEF project in Uruguay provided us with the opportunity for implementation. Previous projects laid the groundwork for us to design our phase out and at the same time share experiences and lessons learned with our region. Next slide. Although we have a regulatory framework that addresses the national integrated health system, this system included dental amalgam on it until 2018. By that time, not only private dental clinics already eliminated the practice, but the academia had also removed it from the student curricula. Since 1999, there was a decree in place that dealt with hospital waste. There was also an update on that decree that included the waste from dental amalgam. And this decree also takes into account the transport of the medical waste. Once, as I told you before, once we became part of Minamata Convention, we began to work on legislation that considered mercury-added products. During the implementation of this CHEF project in Uruguay, we are working on an amendment of this decree that will include a ban on dental amalgam. Next slide. This slide shows the main reasons why Uruguay is undergoing the elimination of dental amalgam. Primarily, Uruguay is not an importer of mercury, is an importer of mercury and products containing mercury. We don't have primary mercury mining, and we don't have also national production of mercury-added products. The last record that we have of import for dental amalgam is 2016. The Uruguayan Dental Association, that is a private association that has professionals of dentistry in it, discontinued the practice some years ago. The Ministry of Health also classified the dental amalgam as an obsolete practice, and currently has an oral health program that is working and active at national level. Finally, we have regulations for environmentally sound management of transport, storage, treatment, and final disposal for this type of waste. The transportation and facilities for treatment of dental amalgam waste are authorized and operate within the territory. And of course, we have restorative materials available and minimally invasive practices that are applied by our professionals nowadays. Next slide. Some of the results of this project in Uruguay is this coordination between ministers, agencies, and other offices, as well as the private stakeholders and various institutions that are collaborators of this project. We have a comprehensive mapping of existing legacy materials. We implemented the collection, treatment, and final disposal for this legacy waste. We focus on prevention and information dissemination with target educational materials. We are on the way of adapting our regulation. We have developed some videos and other booklets that are very important for our communication during this project. And we are actively participating not only in national but regional events, sharing our experience and lessons learned. Next. So thank you very much for your attention, and you have there my contact email just in case you need any information. Thank you very much.
Thank you so much, Judith, and thanks for the great job that you have been leading over the few years as part of this CHEF 7 and showing the way for a number of countries also how to move toward the phasing out of dental amalgam use. Second country experience now is presented by Dr. Manuel Ballesteros, the Chief of the Oral Health and Nutrition Care Division at the Disease Prevention and Control Bureau of the Department of Health in Manila, Philippines. So Manuel is a distinguished pediatric dentist and public health advocate with a profound impact on dental health services in the Philippines. So the floor is yours, Manuel. Welcome again.
Just to let you know, your screen is currently not showing the presentation. We can only see your background screen.
Yes, Noel, could
Okay.
you...
Okay. Thank you, Benoit. Good day to everybody. Today, I've been tasked to give a short talk on the amalgam phase-out experience in the Philippines. Now, you know I'm a baby boomer, which means to say that I grew up during the amalgam era, amalgam being the major filling material in the Philippines for more than a century. As
Dr.
such,
Noel, sorry, we can't see your presentation. If you go to share content and then go to file, you should be able to click on the slideshow. So you go to share, and then beside screen or application, there's a button that says file. And here you can upload or select one that you already have. Still can't see your presentation. It's just the screen. No, still your screen. So if you stop sharing your screen.
Yeah, I'll just use your the PowerPoint on screen.
Instead of selecting PowerPoint, if you could select, instead of screen or application, you select file beside screen or application in the share content tab. Or I can also share if you prefer. There we go.
Okay. Thank you. Good day to everybody. And today I've been tasked to give a short talk on the amalgam phase-out experience in the Philippines. Like what I've said, I'm a baby boomer, which means I grew up during the amalgam era, amalgam being the major filling material in the Philippines for more than a century. As such, changing mindsets on the amalgam as the best restorative material was most challenging. The growing issues and concerns on the health and environmental risks involving mercury prompted the government to institute administrative changes in health facilities, all towards the delivery of a mercury-free healthcare. In 2006, during the Southeast Asian Conference on Mercury in Healthcare held at the Philippine Heart Center, the Department of Health declared the gradual elimination of mercury use in the Philippine healthcare system. 2 years later, in 2008, an administrative order was issued on the gradual phase-out of mercury in healthcare facilities and institutions. The administrative order included dental clinics. Now, the Annex B of this AO presented a sample of the mercury minimization program featuring evidence-based and best practice management for mercury elimination in the usage of dental amalgam. The guidelines include the following: how mercury from dental amalgam can get into the environment, amalgam storage and handling, amalgam capsule handling, and alerts on how mercury can contaminate carpets, floor cracks, and other areas in the clinic. In 2019, the Department of Environment and Natural Resources issued another order called Revised Chemical Control Order for Mercury and Mercury Compounds, which aims to regulate, restrict, or prohibit the importation, use, and disposal of mercury and mercury compounds. Philippines signed the Minamata Convention on 2013. It was ratified 7 years later in 2020, Philippines becoming the 123rd party to ratify the Minamata Convention. Simultaneously, a Department of Health administrative order was released, guidelines in the phase-out of mercury in dental restorative materials. Now, this order is supported by our Universal Healthcare Act, the Food and Administration Act, the Consumer Act, Toxic Substances and Hazardous Waste, and Nuclear Waste Control Act of 1990, the objectives of which is to provide a comprehensive policy direction for the phase-out of dental amalgam in the country, develop guidelines for the phase-out of the importation, manufacture, distribution, offer for sale, and use of dental amalgams in the country. Third is to establish health and safety guidelines. Fourth is to educate and promote awareness among consumers and other concerned stakeholders on alternative dental materials. And fifth is to identify measures to strengthen strategies on prevention and oral health promotion. The salient features of this order include the following. Amalgam shall not be given to pregnant women, children under age 14, breastfeeding mothers, and persons with compromised renal and immune systems. The phase-out period shall be within 3 years from the effectivity of the order, and waste should be collected and disposed of through an accredited transporter or TSD, treatment, storage, and disposal facility. An interagency technical working group was also created to monitor and evaluate the implementation of the order, and our Professional Regulation Commission has already excluded dental amalgam in board examinations and has revised its curriculum for the dentist. On 2022, the Food and Drug Administration issued a circular banning all mercury-added thermometers, sphygmomanometers, dental amalgam capsules, and liquid mercury for use in dental materials. The success of the phase-out of amalgam in the Philippines can be attributed to the following. One is relentless advocacy and lobbying from environment and health advocates, an aggressive awareness program to the public on the dangers of mercury poisoning, the full support of the Philippine Dental Association and its affiliate groups, multi-sectoral collaboration with relevant government agencies, including the private sector, an aggressive continuing education and awareness campaign among dentists on amalgam alternatives, and this includes modern concepts on caries management, such as the minimum intervention, partial caries removal, the use of glass ionomers as indirect pulp capping agents, as interim therapeutic restorations, as sealants, and as root surface protection. Also, the use of glass ionomers in public health for ART. Glass ionomers, its ease of manipulation compared to amalgam. And of course, the use of composite resins for the demand for aesthetics. Also, our Universal Healthcare Act is now putting prime focus on primary care, which is strengthening oral health promotion and disease prevention versus treatment and hospital care. Currently, the Department of Health has come out with our first ever oral health benefit package, the routine preventive oral care, which includes glass ionomers as sealants and for class 5s and root surface protection. So for our ways forward, for the first column, we have our routine preventive care. By the end of the year, we will come out with the essential curative care, which includes the use of glass ionomers as ART fillings and silver diamine fluoride. And we will be coming out with advanced curative oral care, a dental filling package, which includes resin composites, glass ionomers, and RMGIs. Ultimately, despite amalgam's long history and advantages as a restorative material, Philippines chose to protect the health of the public and to love and protect our environment above anything else. A risk versus benefit decision-making process will definitely favor the phasing out of amalgam, all for the safety and future of our children and country. So maraming salamat po.
Thank you so much, Manuel. We know that it's quite late, 8 p.m., I think, in Manila. So thanks for joining this discussion, and great to see another example to show that showing that phasing out dental amalgam is feasible, even in big countries as Philippines. So thank you so much. Now, thanks to all our speakers. Now it's time to address the few questions that we have received in the chat. I know that speakers already responded to some of them, but over to you, Gabi, to lead this Q&A short one session.
Thanks very much, Benoit. So we have just a couple minutes, so we might be able to take a couple of questions. There was one just posted in the chat about the first presentation from Dr. Katia Jodion, that there could be microplastics released from the use of some composite materials, and whether there are pollution prevention measures or technologies available that could be used in dental clinics to prevent the release of microplastics to the environment. And are there any risks of regrettable substitution from an environmental perspective? Or does this require further study? So I don't know if any one of our speakers would like to take the floor first to take on this question.
Maybe Falk, do you want to?
Can you repeat the question once more? Because I was just reading through them because you said I should answer them in writing. So I tried to find questions which directed me. So I didn't listen to you. I'm sorry.
No, it's fine. It's about the release of microplastics from some composite
that was the
materials.
last question. Yes. Yeah.
Yes,
I
yes.
saw that.
And
I think indeed that is a topic, and it is probably a topic which we will hear more about in the future. One thing which we certainly see, not necessarily only the microplastic element, but the BPA. We have a very strong group in my clinic working on BPA release from not only dental materials, all types of materials. We just talked about pacifiers, for example. We analyzed the range of pacifiers, even those which were BPA-free release significant amounts of BPA, by the way, which is scary. So I think from that perspective, we will also look at all the resin-containing materials once more with regards to any releases, and even those which claim to be BPA-free, similar to the pacifiers, sometimes are not really BPA-free because they contain BPA derivatives and so on. So I think looking at the biocompatibility and the toxicological effects of the material is something which we will do more also, for instance, in light with regards to the new EFSA regulation when it comes to BPA and other things.
thank you very much, Professor Falk. There was also another question in the chat about if we could discuss how the WHO position aligns with the 2025 update of the IADR policy statement on the safety of dental amalgam. So perhaps I will give the floor to Dr. Benoit Varenne to answer.
Yes, thank you, Gabi. I don't want to be provocative at all, but for WHO, I think it's no longer the central question, safety or not of dental amalgam. I think it's now time for kind of collective responsibility, to support countries in accelerating the transition toward mercury-free alternative in oral health care. So it's really our position now, WHO. This requires, of course, a lot of collaboration with industry, researchers, civil society, and government. So I think it's for this reason that WHO will encourage parties to the COP to move toward a phase out of dental amalgam use by 2030, including where feasible, to establish also a robust monitoring framework to track progress across countries. So this is really the key priority. We have, I think, now a good amount of strong scientific evidence that alternative free mercury materials and less invasive intervention are available. Now we have to work together to make sure that they are accessible, affordable, equitable, because it's really our aim as part of the Global Health Action Plan.
Thank you very much, Benoit, and thank you to all the speakers and for the good discussion that has been happening in the chat. I noticed that we have not reached really the time that was allocated for the webinar, so maybe I will thank all the speakers now and hand back over to Benoit for the closing remarks. Thank you.
Yes, no, really quick. As you all understand, of course, this guideline is kind of milestone for sure in moving this discussion. There is, of course, the recommendation, but a lot of additional information, explanation. And it's the reason that it's quite complex, a bit dry document for countries and non-experts. But we are planning to launch a strategy in terms of dissemination. We'll organize some webinar early next year to really open the discussion with countries and to ensure that this guideline will really inform the decision making and adapt to different national contexts. So again, thank you to all of you speakers and all the people and colleagues, friends who contribute to this work. A big thank you also for the Secretary of Minamata Convention, Maya, and other colleagues, to support us in the preparation of this webinar. I know that this webinar will be available on the COP6 web and also on YouTube channel. So thank you once again, and let's continue the discussion during the COP6 in a few weeks' time. Thanks again, and enjoy the weekend ahead.
Thanks.